Good morning, afternoon, depending on where you are. Thank you all so much for being with us. I'm going to go ahead and apologize in advance that I have terrible allergies, and so I sound slightly funky. And my wonderful colleague Stacy will save me if I have to go off camera and off mic having a coughing fit. So sorry, that little housekeeping there. We're thrilled to have you all for our Street Institute and Safer from Harm Coalition event on syringe services programs in red states. And really, really thrilled about our panelists today who have direct experience on the topic in a very, very timely issue. And we'll get into just how timely that is as we speak today. But just a brief intro. I'm sure most people attending know this, but syringe services programs, I think, when I was growing up, kind of colloquially referred to as needle exchanges, are one of the oldest and most evidence-based forms of harm reduction. In other words, of ways to reduce illness, injury, and death, even when we know people are engaging in behavior that has risks, such as drug use. These programs provide sterile equipment to people who use drugs, and by doing so, prevent the transmission of HIV, hepatitis C. They build trust in the community and provide a whole range of services and connections to healthcare, counseling, recovery, other essential services, delivering short and long-term value to participants' lives, most importantly in community health, but also to safety, to first responders, and to taxpayers. So there's currently a handful of states that have no explicit or implicit authorization in the law for operation, of certain services programs, which we will refer to often as SSPs. And because these gaps are primarily happen to be in red states, that's why we've convened the panel today to hear from a couple of folks who are doing this important work in red states. I will just note, as we do introductions, we've had one panelist have to bow out due to a conflict, but I think we've got a really rich conversation here. So we're going to talk about today the activities and impacts of SSPs on individuals and communities, the policy frameworks in various states that make these programs possible or that hinder their operations, and what's going on in the states now, and a little bit of hearing from the law enforcement perspective. We're really lucky to have law enforcement officer joining us here today. So very brief intros. I'm Jessica Shortell. I lead our Safer from Harm Coalition, which is a nonpartisan, broad coalition of any organization that believes that harm reduction should be part of our public policy. With us today are my wonderful colleague, Stacy McKenna, who's our resident senior fellow in integrated harm reduction at R Street. Mark Burrows, who's the director of Challenges, Inc. in South Carolina, South Carolina's first and oldest syringe services program. And Colonel Thomas Synan Jr., Chief of Police of the Newtown Police Department in Ohio. And again, with regrets from Teresa Davis at the North Idaho AIDS Coalition, who had a conflict today. So there's a lot of talking from me. Let's just get right into it. Mark, having operated now for a very long time, the oldest SSP program in South Carolina, could you give us a brief overview of what they are, what SSPs are, and how and why they operate, including, what they do beyond syringes?
Yeah, certainly. Thank you so much, and thanks for having me here today and representing South Carolina. That could be a huge definition of what a syringe services program is. But first and foremost, I mean, they are programs, usually nonprofits, but also could be other entities, FQHCs or health departments, um, that are providing non-judgmental, compassionate care for people who inject drugs and also people who smoke drugs. Um, and so, their focus would be reducing the spread of infectious disease like HIV, hepatitis C, bacterial infections like endocarditis, MRSA, sepsis, um, and you know, so preventing the spread of these infectious diseases, preventing overdose, right? So lots of naloxone distribution, Narcan distribution, and then other things too, like more like ancillary services, like getting people connected to care, whether that's treatment for substance use disorders, treatment for infectious disease, and even more that like social services, housing, employment. So really, the list can go on and on, but that's I think the key difference, like the kind of niche of a syringe services program, is these are programs working with individuals who are still actively using substances. And that's a key difference from any other component in the healthcare or addiction treatment landscape, is that SSPs are working with people who are actively using drugs.
So, Stacy, there's a lot of data, decades, around the impact of certain services programs. Can you give us some of the highlights of how these programs impact people in communities?
Yeah, so as you said, we've got decades of data on this particular intervention. SSPs have been around since the 80s. We see, according to the CDC, we see a 50% reduction in HIV and hepatitis C. But that's not all, right? There's also substantial reductions in injection site infections and the related complications, things like that. I think one of the things that's come out recently that's really compelling, especially for a lot of red states, a lot of more rural communities as well, is that a lot of the early data on SSPs came from big cities, right? That's oftentimes where these programs were popping up, where these communities were doing this for themselves. But a recent study from all over Kentucky, which looked at, I think, 80% of the communities they were looking at were rural. And they found the same types of benefits in rural communities, right? So things like reductions in endocarditis, reductions in HIV, reductions in hepatitis C. And they found that this all started to happen within a month of a program launching, which is pretty compelling. In addition, participants are 4 to 5 times more likely to enter treatment and about 3 times more likely to stop using drugs compared to folks who are injecting drugs but not participating in an SSP. And even those people who do continue to use while they're accessing these services, they tend to use less chaotically. They tend to reduce their use. And so even sort of while they're on this journey and at whatever phase they're in, it's often there are fewer repercussions for themselves as well as for the loved ones in their lives because of that while they're engaged with these programs. From a taxpayer community perspective, right? That's another big piece. We know these programs are really important and beneficial to the people who are participating in them, but they also are beneficial to the broader community that these people are part of. Every dollar spent on an SSP saves about $6 to $7 on HIV-related costs alone. It costs an estimated $400,000 to treat a person for HIV over their lifetime, since it is no longer an automatic death sentence, it's a chronic illness. But so every dollar spent saves 6 to 7. What's more, when we see programs like what Mark was talking about that have these really compelling wraparound services that really pull people in and provide a number of different services and referral, the cost effectiveness just goes up. When we see really locally oriented programs where we're allowing the local people on the ground to make decisions about the best way to engage their participants, so say maybe that's a mobile van or something like that, we see the cost effectiveness and the effectiveness go up. So I think from a policy perspective, this really highlights the importance of letting the experts on the ground, like giving them a little leeway to adapt to the environment. And then finally, one of the things that I know folks worry about all the time is the presence of syringe litter in their communities. And are we putting a ton of needles and syringes out into the world? And what's kind of amazing is when you look at the data, and this isn't that surprising for folks who see how these programs work, but SSPs are found to reduce the presence of syringes in the community, right? So they improve safe disposal practices. A study in Miami found that it reduced syringe litter by about 50%. And coupled with this, right, we see reductions in needle stick injuries, particularly among first responders and law enforcement officers. And I could go on, but I've been rambling, so I'm going to stop and hand it back to Jessica.
Thank you, Stacy. And again, for anyone joining late, I'm sorry that I'm drinking hot tea and going on mute a lot, but I am filled with allergies, so I'm trying not to bother you all. Chief Sign-In, so this is actually a great segue. Good job, Stacy. Your work in the greater Cincinnati area for years now, right, touches on many aspects of the idea of harm reduction, that people can do things to keep themselves and others safer, even when they're engaging in behaviors that have risk. So that's everything from y'all provide naloxone for opioid overdose reversal, medications for opioid use disorder in local jails. What is it about syringe services that make them an important part of this picture for the work that you all do? And I know we could spend an hour just with you alone. I feel very lucky to, but would love to hear that in a little bit of a nutshell to kick us off.
Yeah, I'll see if I can condense it. So the Cincinnati area obviously was one of the hardest hit areas among others in the country, especially when carfentanil hit our streets. At one point, we were seeing nearly 200 overdoses in a week, and Cincinnati police alone, just Cincinnati police alone, were responding up to 40 overdoses a day, just them. So we learned a valuable lesson that harm reduction is the first step to the next step. And in that emergency mode, we needed to keep people alive. We needed to make sure that some of the peripheral issues weren't we weren't impacted by the peripheral issues. But the other thing was we wanted to build a continuum care model. And in order to get that continuum care model, you needed that first step, which was SSP, harm reduction. It is still an integral part of our response, overall response. And we did that with a community coalition that started with about a dozen people, has over 700 individuals and nearly 250 separate organizations in it. And having harm reduction as our key focal point in the beginning helped us reduce overdose in the past 2 years in half. Reported overdose has been cut in half, and reported overdose deaths have been cut by 27%. So we would not have got there without that first step of harm reduction. So it's really important. And as part of our continuum care model, any part we're working on the coalition, the community, that is the first step we put in place.
I think that's so important because we so often hear opponents to syringe services programs try to boil them down to syringes, and that's it. They're nothing else. They don't provide anything else. They don't hook into anything else. And what we're hearing from all of you is just how integral a part they are of a big picture where opioid crisis is not a territory for silver bullets, right? And no one is claiming that syringe services programs are a silver bullet. There are none, but they are such an important piece, which is why the policies that enable or hinder the operation of syringe services matter so much. So I thought maybe we could segue into talking about syringe services and state laws today. So Stacy, if you could help us with big picture, since you look across the whole country, what is that picture across the country when it comes to legal authorization to support an SSP?
Yeah, so some of the legal interpretations of these laws vary a little bit, right? But so we're based on a couple of studies from the Legislative Analysis and Public Policy Association, and then just looking at the laws ourselves, about 10 to 12 states, sort of depending on the law's interpretation, either lack either implicit or explicit authorization to operate an SSP, right? So this means that there's nothing, this might mean that they have a paraphernalia law that includes syringes, and they don't have any kind of carve outs for a syringe service program. According to the National Association on Syringe Exchange Network, they say 43 states and Washington, D.C. have operational SSPs despite this, right? So that leaves us with 38 to 40 states that don't have authorization, but the programs are operating maybe in 43 states plus DC. Another analysis said 45 states plus DC. It's a little tricky, right? Because in those states where it's a legal gray area or there's not official authorization of any sort, it gets tricky because they're maybe wanting to stay a little bit more under the radar. The states that do not seem to have any, or we mentioned them earlier, Wyoming, South Dakota, Nebraska, Kansas, and Mississippi do not seem to have any actively operating syringe services programs at the moment. I think the other thing to keep in mind is the state level policies authorized, when they do authorize syringe services, vary dramatically. Some of them allow state funding to be used for all of the above, like for all of the services. Some of them don't allow any state or local government funding to be used. Some of them require local authorization. Some don't require local authorization. Some require good relationship, like active relationships with law enforcement. Some don't require that. So they're really varied and really built into sort of whatever the bigger policy landscape is and political landscape of that state.
So Mark, then in South Carolina, let's talk about South Carolina specifically, where we hear the terms legal gray area constantly. And some would disagree that there's a legal gray area. I would love to hear what you make of that. But interpretation of whether South Carolina law allows or allows operation of SSP seems to vary depending on who you ask. So what are those varying opinions? Obviously, you operate these programs in the state. Where do you land? And how does that gray area impact what you can do and the way you operate?
Yeah, the legal gray area question is sometimes like my favorite thing to talk about, and then my most despised thing to talk about because it's it's funny. It's like it's either a really huge issue that prevents a ton of great work, or it's not so much of an issue and we get along just fine. And it's always like waxing and waning. However, and so there's kind of like three interpretations. There's and this is changing, but years ago, 2016, 17, when I started this, um, the overall perception was that they were illegal. If you were to ask anyone who's anyone, they would say SSPs are illegal. Well, then we kind of found out, well, that doesn't seem to be the case. Obviously, we're operating, we're not being shut down, so it must be a legal gray area. And then more recently, in the last couple of years, a brilliant public law policy expert attorney named Corey Davis, who I like to pester frequently to help figure out this policy puzzle. It's his expert opinion that it's actually not a gray area, and it's just that it's not illegal in South Carolina. We don't have a law that explicitly prohibits SSP work. So very confusing depending on who you ask. Um, for us, we've since day one, we've always been very public, out in the open. All of the powers that be know that we're here, other community partners, organizations, everyone knows we exist. We've been mentioned in the media and local news many times. We've never had any legal consequences. We've never had any legal problems. Where it really becomes an issue is the funding aspect, um, whether it's accessing local, state, or federal funds. And then really the expansion aspect. So like when we talk about like expanding SSPs, um, if you want to be someone like, my program and just you're willing to take the risk and find money where you can find it, then you can do so. But if you're a larger, well-structured, more sustainable organization, you're probably not as willing to take those risks. You might think you're jeopardizing funding streams or relationships with state agencies or board disagreements, whatever it may be. But so the legal gray area issue really prevents other entities from getting involved in this work, which is really a shame because there are entities that support and would love to do this work and would be a good fit for this work. But however, they're unable to kind of jump in at this point. So that's really what we see with the legal gray area. I'm trying to think back on the rest of your question. Uh, I guess, but yeah, that does seem, I mean, that seems to be the case I guess you can, whether you think it is illegal or not illegal, it's like kind of like all of it is true. So then I guess the legal gray area is a good definition for the status in South Carolina.
So out of curiosity, I know the answer to this question, but what what would make you decide to start a program in a messy legal gray area if there is one? Why do
Yeah,
it?
well, I think at first I was naive and ignorant and probably didn't know. I mean, so at first it was like, I have lived experience with substance use and infectious disease. And I was working in the substance use disorder treatment field, the addiction treatment field. And I noticed like, hey, like a large percentage of people being treated for addiction also have hepatitis C, for example. But the hepatitis C is not being talked about. It's not being worked on within that addiction treatment landscape as it was back then. And so it just made sense to me. It's like there's a huge overlap here of, hepatitis C clients and substance use clients that are overlapping. Yet we're not talking about it within that industry. Um, so that's where my desire came from, to start this and prevent other people from going through what I had gone through. It's way easier to prevent these things from happening than to treat them afterwards. And so it was really just going on this journey. And I guess, in all of my research and networking and having meetings with people, I guess I could tell that there was a discrepancy between what I was being told by like agency departments or agency directors or, whoever was telling me that it's not possible, it's illegal. And then, what I was seeing, in our legislature. I knew like something wasn't connecting there. And so I guess it made me feel comfortable enough to take the risk and jump out on my own.
So speaking of the legislature, you've got a live bill in South Carolina right now, filed by a conservative lawmaker that would give that full clarity to any doubters, right? Is that accurate portrayal? Can you tell
It's
us a little bit about the bill and who's supporting it and what its impacts would be?
Yeah, certainly. So it's a beautifully well-written bill in our opinion. Um, we had years ago, we had a Democratic senator propose a similar bill, although written much different, but also a syringe service harm reduction bill. And it never moved anywhere, right? And so we always knew that we needed a Republican sponsor if we were going to make any progress in South Carolina. And so, yeah, Senator Tom Davis out of Beaufort County, South Carolina, has decided to take up on this issue. And the reason I say it's a really nice bill is because it doesn't provide overly, an overly amount of oversight, government oversight regulation. It's a very simplistic bill, and I think that's a win-win for the people doing the work and for the legislature. Um, and so last week it went in front of the Senate Medical Affairs Subcommittee, and community members were able to give testimony, including myself. The South Carolina Harm Reduction Coalition had a good turnout of supporters. We had other champions of this work who showed up in support, and it went really well. And so it passed subcommittee with a 5-2 vote. I believe two of those favorable votes were Republicans. And so this is huge progress and a first, in South Carolina. So we have a long way to go, but we're very excited about that first step. And, also important to mention, there was no opposition. So no opposition in testimony for that bill. So I think that's a nice sign of the landscape here in South Carolina.
Great to hear. Speaking of legislation, Stacy, do you want to play breaking news reporter? We are no news has broken, but we are in the middle of a similar bill having passed in Nebraska, passed through the unicameral legislature in Nebraska with a very strong bipartisan vote and the support of the speaker. Well, I guess I'm just doing this, Stacy. I was going to toss it to you, but I guess I'll just explain it. A bill that does not authorize syringe services all over the state. It allows local city councils and the like to authorize operation of a syringe services program if they wish to. So it adds another layer of approval that would still have to happen. Nebraska has seen some huge kind of weird upticks in HIV cases where they're going down in other parts of the country. The bill was vetoed by the governor of Nebraska last week. And in a case of our timing is way too good, the unicameral legislature is literally debating it. I've got it on split screen on closed caption right now. And we will see if they have the votes to override the veto and sustain and bring the bill into law. We will probably know that by the end of this event. massive metaphor alert. The whole chamber just evacuated for a couple minutes due to a fire alarm having been pulled, but they're back and debating. So this is like the real sausage getting made. We also have some things I will now toss to you, Stacy. Some things afoot, debates afoot in Idaho, and I wondered if you could speak to that a little bit since Teresa wasn't able to join us.
Yeah, for sure. So I guess several years ago now, Idaho legalized syringe service programs. And actually a big part of what drove the adoption of this law in Idaho was protection of public safety and reduction of needle sticks. The state's like trash services had gone on strike because they felt like they were endangered because of the potential for dirty needles. And so there were some unusual champions of the bill in that context, and it got a fair amount of support passed. They have had syringe services in Idaho since I think 2019 now. But in the last year and a half or so, there's been some controversy. It started with funding, wanting to remove state funding for some of these programs. Interestingly, not because of the actual syringe service work they were doing, but because of some of the folks they were serving being trans, and that goes way beyond the scope of this conversation. And I think is just indicative of what sort of has become part of the problem in Idaho, is that syringe services are getting tangled up in arguments that don't really have anything to do with the services that are being offered. And so more recently, there has been a bill introduced. There's been some more controversy recently around one particular program, and associated with that, the introduction of a bill to repeal syringe services across the board. This is, from my perspective, really disheartening. I think from anyone who has seen the benefits of these programs to communities that they're serving, really disheartening. When you look at the Idaho Department of Health and Welfare at their website, you see that they have distributed tens of thousands, if not more, needles and syringes, right? They've distributed loads of safe supplies. They have reduced local incidents of HIV and hepatitis C. They have referred hundreds of people to treatment. And they have directly collected something like 90% of the syringes that they've distributed. This is particularly compelling as a statistic in Idaho because they don't actually so even if they're mailing to folks, they're giving them a safe way to dispose. So now people have sharps containers, and they're allowed to dispose of sharps in the trash in Idaho, but now they have a safe way to do so. And so not only are they collecting the majority of what they're distributing, they're also, for all the rest of those syringes, they're giving people a safe way to dispose of them to keep their communities safer. And that's really important. It's unfortunate to see a sort of knee-jerk reaction to a bigger political and cultural divide going on within the state, that really these programs aren't an inherent part of. These programs are trying to serve the populations that they're trying to serve, and trying to help reduce infectious disease and overdose risk. They've been distributing naloxone and have their naloxone kits have been used to reverse many overdoses. I should have pulled up the data, but I'm afraid it'll take me too long to look at the specifics right now. But yeah, the programs really have had, they've been collecting information and they've had a good impact, and they are really committed to serving the communities that they work with. I know the community that the speaker we were supposed to have, Teresa, works with is very rural. It's very hard for these folks to access any kind of connection, right? And when we talk about the rural West, for those of you who are not out in the rural West, it looks real different than the rural East. It's like a 4-hour drive to get to anything in some of these places, like the grocery store, let alone a treatment program. And so having folks who are really committed to outreach in that context and making sure they continue to serve those individuals as well as people living in the cities is so important. And Idaho's really, like, their SSPs have done an amazing job of that kind of outreach. So it's unfortunate to see this sort of knee-jerk attempt to roll back the legislation. I don't know yet what it's going to do, but I'm hopeful that they'll hear enough pushback and sort of ask for pragmatism and a cooler head in assessing the value of these programs in the community.
It's been wonderful to hear voices across the political spectrum speak up in support of these programs. A notable one is Dr. Jerome Adams, who was the U.S. Surgeon General under President Trump. Before that, he headed up the health department in the state of Indiana under Governor Pence and was instrumental in getting syringe services set up there in a rural county with an HIV outbreak. And I know that county commission recently voted not too long ago to shut that program down. So there's been some scrambling to set it back up. It's been hugely effective, similar to the data you share, Stacy. I think in its life, that program in Scott County, Indiana, had a 92% syringe return rate. So, you know, the worst fear mongers about needle stick injuries and what have you, and maybe Chief Signing can speak to this as well, actually the reality tends to be the opposite, that these programs offer a lot of avenues to create more safety in communities. So on that point, let's talk about then what are the most, you operate in urban and suburban Ohio. You've got to deal with all kinds of folks. This is a panel about syringe services in red states. So what are the most compelling, more conservative facing arguments and evidence that you have seen and experienced and come across for syringe services programs? I know you have some personal experience as well with keeping yourself safe that I think is really compelling.
Yeah, I think Stacy kind of hit on this in the beginning when I'm talking more towards the conservative group, and we actually have some strong partnerships. Some of my strongest partners in the state are Republicans. And one of the reasons is I've been personally stuck twice by needles, and I've had to go through the hepatitis C and HIV process. So I think Stacy hit on it a little bit especially from the conservative side, is how do you keep first responders, or how do you keep the public, quote unquote, safe? And anytime you can reduce that risk, I think that is a good conversation piece, a good argument to push back on and say that having SSPs does help reduce that risk, not only to the first responder, but if you're going to be someone who is going to throw out the argument of the risk to the community, that helps reduce the risk also. But the other strong argument, and actually it's not me leading it, it is often the conservatives, is the cost of jail. A lot of conservatives are really understanding that the cost of jail, I mean, you got to think about this. If you're in a state, your state is often running these prisons, unless they're going private, but it's probably still money. They're going to that state legislator and saying, hey, we need more money. We need to expand. And they're going, well, isn't there a better way to do this? And I think Stacy pointed out some of those costs. When you put out those costs, they start saying, the conservative side starts saying, wait a minute, it makes sense to do this. But one of the things I really highlight when we're talking about SSPs is that it's not just an exchange. Ours is run by public health, who is giving some first aid, some treatment, some care, some medical care on the front line. But there's a peer navigator that's with them. And that peer navigator could connect them directly to treatment if that's the next level. But one of the things I think is missed with this in the bigger discussion is that relationship. When you build a relationship, you build trust. When you build trust, often in a group of people who don't understand or see trust often, when you build that trust, it allows them or gives them an opportunity that if they need some kind of medical care, harm reduction materials, or they need treatment, guess who they go to? That person that was caring for them, that person that listened to them, and that person that they could trust. And we've had many experiences where people have come back to the SSPs and said, I need help, or I need help with this. And it's a connection to many resources too. It can be connection to housing, transportation, jobs, family services. It is really out in the community. And I tell people there's often this kind of phrase that goes out and says, we need to meet people where they are. My added point to that is not just meet them where they are, let's make sure we don't leave them there. And when you have an SSP that's in the community, they're making sure that those community members get that services that they need. So from a conservative level, it's saving money, it's reducing jail space, and it's also solving a problem. And you can start arguing the chronic mental medical health condition instead of the responsibility of someone, quote unquote, with addiction. So I often hear that on the conservative side is we need to hold people responsible. My thing is let's help them, support them to be accountable towards treatment instead of holding them responsible for a chronic mental medical health condition. And when you can kind of combine that from the conservative side, I think it really makes a big difference.
Mark, are you seeing that? Are you seeing the conversation or the support changing, becoming, or maybe it always has been, more bipartisan in South Carolina? What are you seeing?
Yeah, for sure. I mean, I obviously we have a long way to go in South Carolina, but we have come a long way as well. And um, for us, it's really just been like grassroots advocacy and educating the public and community partners, right? I mean, it's, we often get asked like, how do we deal with the pushback doing this in a state like South Carolina? And my answer is always, there really hasn't been that much pushback because, in my opinion, once people are educated on the facts of this work, it makes sense to them. It's really hard to argue with the numbers and the 30 plus years of research and data that we have, right? So, of course, anyone is going to be ignorant to something that they don't understand. And so I just feel like we've won a lot of people over and changed a lot of minds just by providing simple education. And, we do these presentations where it's literally just kind of like a program overview. PowerPoint slides, and I just talk about what our program looks like and what the work looks like. And usually at the end, you see some head nods, and it just makes more sense to people. Um, I had an interesting situation yesterday where a Baptist church that sets up right there, or a Baptist church that is in the area where one of our mobile units sets up, and they had a boiler room where the furnace is, and an unhoused individual was living in this space temporarily, and there was lots of needle litter, tons of needle litter inside this room. And so they were at their wits' end. They were hitting all these dead ends trying to find organizations or companies that would come clean this up for them. And of course, nobody will do it. And so somehow they stumbled upon us, and we were happy to show up and clean it up. But it's a funny point that gets missed is that if you removed our program, there's currently no system in place in South Carolina to pick up syringes, discarded syringes. You can call the health department, they won't do it. You can call the local law enforcement agencies, they won't do it, which is a really interesting thing. I think that people don't realize, like if you found a needle on your street, there's nothing in South Carolina currently to handle that issue. So, I'm glad that that's a gap that we can fill and a service that we can provide. But so, definitely a needed area for this type of work. But yeah, I think, the other thing I was going to say about that, as far as like, what are attitudes these days with this type of work? It's come a long way, and what it is it's always like who's going to do it first, right? Who's going to make the first move? And so now that enough people are starting to make that move and support SSPs, more and more people are coming to the table, right? So last year, our state's largest hospital system, in collaboration with us and some other people, decided to organize the first syringe service symposium in the state. And this is a large organization. They're the biggest employer in the state. They have a lot on the line, right? And so here they are putting up their own money to organize and host a conference, and that says a lot about where we are as a state with this stuff. That would have never have happened years ago. And we're seeing that in other ways, right? Like our health department now has they have a quarterly committee meeting that's talking about these interventions. And all sorts of stuff. So definitely have seen like a shift in attitude and perception as far as talking about this work.
It feels like I'm sure a slow build, but thank you for doing it. I'm
Yeah,
glad.
it takes a long time.
Yeah, yeah.
Yeah.
Chief, are you seeing similar? Are you getting pushback? Are you getting misinformation, misconceptions? Does that come at you pretty regularly? How do you handle that?
Yeah, sure. In the bigger cities like Cincinnati, Columbus, and Cleveland, who've been overwhelmed with these issues, you don't get as much pushback. They're a little bit more open. I tell people we have to struggle with our own thoughts and opinions. And when you struggle, you open the mind. When you open the mind, there's more solutions. So one of the things you hear from people who are not overwhelmed in their systems is that they believe that the old ideologies, just because they're familiar, actually work, but they don't. It's just familiar and you're not seeing that overwhelmed experience. So you believe it's working when it's really not. And I'll hear a lot of people say from who don't have that overwhelming experience, they'll say, well, SSPs enable drug use. And my argument back to them is we, the criminal justice system, are some of the biggest enablers of addiction that there is because we don't open our minds, because we don't struggle with these concepts, because we don't have resources that connect people. When you open your mind and struggles with these concepts and you can hear a different side and see some other avenues, you open the doors. And that's what we did here in Cincinnati. We said, wait a minute, what we've been doing hasn't been working. Let's try something new. We've never done it before, but we always said, let's struggle with our opinion. And when we did, it took us down a path that really opened up a door that helped us succeed. So that's the biggest thing I tell people. You may not have the resources. You may not think that you have the issue. You may think that you're doing the right thing, but ultimately, when you struggle with your opinion, you'll find that there's actually another door that needs to be opened.
I'm back from coughing. I apologize. That's so insightful. And I wondered actually if we could dig a little bit more into the law enforcement piece of it. When you and I first talked, Chief, you mentioned that working with SSPs have provided one of the most important real-time understanding for you and your colleagues about what's happening with the drug supply in your community and how that empowers you to keep people safer.
Yeah,
So I'd love to hear a little bit more about that if you're willing.
yeah, absolutely. It's fascinating. You would think as law enforcement, I would rely on law enforcement data, but that is actually on the lower part of my list because if you think about law enforcement when it comes to drug intelligence, we only talk about what we get, what we catch. We don't talk about what got through. And often when you talk to people who are actually on the street who are using, they have the most up-to-date information. The first time I ever heard of fentanyl, it was called China White, was from someone that was using. And I'll give you a specific example that we used in the coalition that was pretty significant. When COVID hit, we knew that Wuhan, China was one of the primary places for fentanyl precursors, manufacturing, shipment, all of that. When COVID hits Wuhan, China, one of the first discussions we had as the world's starting to shut down, how is that going to impact fentanyl supply? It goes to a harm reduction conversation because when you disrupt fentanyl supply and it comes back online full force, you're going to see a huge increase in overdoses and overdose deaths. We were planning months in advance on how do we prepare for this as the world's shutting down, the United States is shutting down. I'm meeting weekly with harm reduction specialists in their meetings as they're talking to clients on the street, getting real-time information how fentanyl is being diluted, how fentanyl is being hoarded, how you're starting to see some of the more drugs that we saw back in the past, like crack cocaine, heroin itself, which really was a strong indicator for us that drug supply had changed in our area. That meant that we had to be prepared for an increase once everything opened up. We changed harm reduction response. We were actually going out giving Narcan and harm reduction materials on people's porches. We were making sure they could still get to hospitals, to treatment. And then when the United States and the world opened up, we, like everyone else in Ohio and the country, did see an increase, but we recovered much more quickly because of that intelligence. I'll call it intelligence. It was really a group of people just sharing information
Yeah,
and
insights,
helping
right?
each other because I was able to go back with the harm reduction people and tell them what we were working on, and they were able to implement a lot of the programs on the street. So some of the best partnerships I've ever had, if I'm just going to put on my law enforcement hat, has been my harm reduction friends who give me real-time drug intelligence information. It's not meant to go after somebody. It is meant to know what's in drug supply so we can respond better as a community. And it's really been a partnership that I continue today, been for 8 years. And that partnership and that information is really some of the driving force in how we've been able to reduce reported overdoses and overdose deaths. It's a new look at it. Don't look at it from just a law enforcement lens, but how can we make it a prevention? How can we connect resources? And how can it be part of our continuum care model?
Mm-hmm. Yeah. Yeah. So one piece of the puzzle, very complex puzzle rather than individual silos. That's fascinating. Mark, what's your experience with your programs and connection with local law enforcement? Are there things that work well there that need more work?
Yeah, it's been like everything, it's been a long time coming, a lot of, a long time in the works, but it started with um one law enforcement advocate for harm reduction who we had made relations with, and she I forget her title, but she's kind of like a community outreach liaison police officer. And she has been like, you could tell she's been interested in what we do for many years and has slowly been trying to like figure out ways of working with us. About a year ago, they had a program where they were um, trying to set up like a referral service, like law enforcement, other providers trying to act as a referral source for people who needed SUD treatment. And what they found was that their numbers were really terrible. I think in 6 months they had one person referred, because people didn't want to engage with them, right? Um, so so we were able to offer our partnership with them and say, hey, if you allow us to set up along with you, maybe that would help your numbers, It got shut down initially because her supervisor, they couldn't wrap their heads around, and again, this is kind of where that legal gray area comes back. They couldn't wrap their heads around as law enforcement with, okay, how are we working with this group that's providing access to sterile syringes over here, but on this side of town, we're arresting people for syringes, right? So they, as an agency, they needed to like figure that out. And it wasn't but maybe 6 months later they came back to us and said, okay, we're ready to give it a shot. And I don't know what changed on the internal side with the agency, but obviously something happened. So now we set up with them every Wednesday. We set our mobile unit up with, they have some services in the same parking lot, and there's police cars there and syringe service participants visiting the same location, and everyone gets along. I will say though, it is bittersweet because all of these things, and I was kind of testifying to this last week, these are built on like handshake agreements, right? Like, so it's still not like the politics within our local law enforcement agency. The politics are still not fully there where they're ready to make like an official MOU or contract or some sort of formal agreement with a syringe program. So it's really built on those personal relationships and those like handshake agreements. So like I said, it's a win, but it's a little bittersweet, right? Because it would be nice if it was something more formalized and more official. But that's how it works for us, and that's how we've had to do everything, is just like building these relationships and slowly winning people over and getting a shot to prove ourselves to them, essentially.
So I'm just going to pause for a second and say, if folks have questions, the Q&A function is open. Please drop them in and we'll move to that in just a second. But what you're saying, Mark, is just making me want to toss to Stacy one last time, because all of those relationships, all of those handshakes can be in jeopardy in the face of especially kind of concerted and coordinated misinformation about what syringe service programs are and do. And we're seeing a kind of another wave of that right now in various places, Stacey. And I just wondered if you could speak to kind of the main thrust of the argument that we're seeing in Nebraska, in Idaho, and a few other places, the same source being cited, um, uh, and whether there's any merit to the information that's being shared to oppose syringe services programs.
Yeah, I think, you know, at the same time as we're seeing some of these really promising conversations and relationships build in some red states, we're also seeing a lot of pushback. And that pushback seems to be coming in the form of, as you said, Jessica, misinformation. So there's kind of two big things that we hear over and over again. The first is this just sort of general fear that we're going to become San Francisco, Canada, New York City, insert community your state doesn't want to be. And I think, you know, one of the things that's really challenging with that is these are completely different fruits, right? Like Nebraska is not going to become San Francisco, no matter how many syringe service programs it has. And I think, you know, what a lot of the best argument I see to that particular fear is look to states like North Dakota, where they have been operating SSPs and serving their communities and keeping people safer and healthier. And they're doing it in a way that makes sense for North Dakota. And nobody can tell me North Dakota is becoming San Francisco. The other thing we're hearing more and more is that syringe services don't do what we say that they do, that they actually endanger people who use drugs, specifically leading to a rise in overdoses. And that is coming from a study by an economist that it started out as a working paper, was published in a peer-reviewed journal. I believe it was about a year ago. And unfortunately, while the math in the study is okay, the broader design and the context-based understanding of that study are really problematic. And the biggest problem I see with it is that the author just looked at whether the population level overdose death rates increased after the implementation of syringe service programs. There's some additional methodological problems with the way that they assess, like, decided which syringe service programs to use and not use. Like, they didn't include ones that had closed down and things like that. But the biggest problem with that is that when you look at the spread of fentanyl throughout the United States, yes, we saw a rise of fentanyl in the illicit supply in 2013, but that was in some communities. And so it has been community by community, region by region. It has varied drastically and considerably. And the people who are most in tune to this, as Chief Synan mentioned, right, are the folks on the ground. It's the people who are potentially overdosing. It's the people who are working directly with them. And it's maybe your local law enforcement who has the insight to be working with those people. And those groups together are very likely to have come together as they started seeing a trend in a rise in fentanyl and their supply to say, man, we should have more of these programs available to folks because they have overdose education and prevention programming. And so what you might see is on the ground intel means, okay, let's open up a program. The program opens, the market gets flooded around that time, and you see a spike in overdoses. So it's a false correlation. There's not really a causal relationship there. The other piece is that her data collection, I believe, ended in like 2016. And while syringe services have been distributing naloxone directly to folks who use drugs since the 90s, they haven't had easy access to it in large quantities until much more recently. And part of that's because of policy restrictions that kept prescription regulations and things like that. It gets complicated, but it's really only in recent years that we've started to see enough naloxone to start to make a difference. So these organizations were not sufficiently equipped with the supplies to give people to really help reverse those overdoses as fentanyl surged onto the scene. So I think it's a good reminder to us that, like, the importance of thinking about these new studies, like, be open to that new data. We need to be open to it and think critically and openly about it. But we also need to put it in the context, not just of past research, but what we know about the current environment and the current drug supply.
Thank you. I will now just pause to say that my heart is pounding because the Nebraska legislature is voting in about 15 seconds to see if this veto will be overridden and bring these potential for these programs to Nebraska. So I will breaking news it if it happens while we're talking. I'm going to try to go to a question. We've got someone asking what a panelist view as overlapping outcomes of interest between law enforcement, criminal legal system, communities, and public health harm reduction advocates that may be helpful in aligning. Like where in the Venn diagram, I think this person is asking, what's the sweet spot that works for all of those groups? We've been over this a little bit, but I think it absolutely worth reiterating. Anyone?
I'll just jump in. I mean, I think it's a lot, any like improved well-being, but probably overdose prevention, overdose response, right? That's going to be a big overlap with all first responders, harm reduction, other groups. And then linkage to care, right? That's the big one. Everyone wants to see people linked to whatever care it may be, SUD, primary care, infectious disease, and so I think all of those entities overlap with those interests.
I was going to say, from a law enforcement perspective, we want to save, ultimately we want to save people's lives, and it does bother us when people die. And when you see someone overdose multiple times and then they die, it ends up having a huge impact. So that next level care, it allows us to not feel helpless. So I don't think necessarily law enforcement is saying the outcome has to be XYZ. I think what they're looking for is, can this person get the next level care? Do they know that they're getting that next level care? And is there a pathway for them to get towards treatment, active recovery, or whatever it may be? Whether they decide to or not is not the issue. Is there a pathway to do it? When we know there's a pathway, we feel much more confident and we don't feel as powerless than just going out and meeting somebody where they're at. I'm telling you, from a law enforcement perspective, the just meeting somebody where they're at, we walk away, and it's very painful for us to do that, especially when they overdose and die. So having that connection, whether it's QRT, a peer navigator, or at least the avenue, gives us some hope. And that's all we really need when it comes to law enforcement. Give us a little bit of hope and we're on board.
Vote is underway in Nebraska, so if y'all want to stick with us past the hour, I'll tell you the results when it happens. This feels way too Truman Show, real time. But we got one more question if y'all have time for it. How's it going with influencing state level administrators, especially in red states, of SAMHSA funding to direct more money to syringe services programs versus to maybe non-evidence-based programs that are more culturally accepted?
Yeah, I'm happy to speak to that one too. And we kind of got asked this question in our testimony last week again in the Senate, which is a little above my head, some of that, decision making around federal funding. But, like in South Carolina, it's basically the powers that be who control or manage SAMHSA funding have not yet decided to allow that funding for SSP work, or they haven't gone after specific types of federal funding for SSP work. That's my one interpretation. And secondly, then it kind of gets more creative than that, right? Because we do have funding for some like opioid response funding for Narcan, right? So we do receive some state funding for Narcan and fentanyl test strips. It's just that they're not being utilized within SSPs because, as far as the state is concerned, that doesn't exist. So it's more like Narcan community distributors. So I don't know if that helps answer that question, Colin, and good to see you on here. But it's just like in South Carolina right now, it's like the state and the SAMHSA dollars don't really recognize SSPs. So what that means for a person doing SSP is you have to get creative with that and use like Narcan funding to reallocate your syringe funds, or different things like that. You have to get creative with like how you're using that funding to staff positions in your SSP, even though they're not specifically designated for SSP. I hope that makes sense.
It does. We are at the top of the hour. Thank you for that. This is not how I would like to end this session, but the LB 307 in Nebraska was just the veto held, the override fell 3 votes short. So that bill will not become law, and I think makes this conversation and all of your work so much more timely, and is a charge to all of us to continue to share both the facts, but also the compassion that both of you bring to this work, Chief and Mark. That it's that kind of very powerful combination of evidence and humanity. So I think, you know, this is just, I think, strengthens our charge and our resolve to keep sharing that information as far and wide as we can. So super grateful to you all for bringing such integrity and compassion and care to such an important issue on a tough day for the issue in an important part of the country. So thank you so much for everything that you do, and please keep going. Thank you all for joining us. We really appreciate it. A video of this event will be available on our website. You should get an email about it if you RSVP'd. So we'd be grateful if you'd share it. I think today's vote in Nebraska lets us know that more people need to see conversations like this. So thank you all so much.